welcome you to this session. Our session is on anesthesia monitoring. So if there is any forever, kung meron forever sa anesthesia, it's anesthesia monitoring. So welcome. Uh, I will introduce the three speakers first, and then after they have given their talk, then you can ask the questions. So our first speaker is Dr. Stephanie Jane O. Xiao. Dr. Xiao is a graduate of the University of Santo Tomas Faculty of Medicine and Surgery. She finished her residency training in anesthesiology at the University of Santo Tomas Hospital and pursued her fellowship training in regional anesthesia at the Medical City. She is currently a member of the Chinese General Hospital Anesthesia Residency Training Committee. She is also affiliated with USTH, Hospital of Infant Jesus, Metropolitan Medical Center, and Peregrine Eye Institute. She will be talking on the end-tidal CO2. For our next speaker, we have Dr. Maria Vanessa A. Christie. Dr. Christie graduated from the University of the Philippines College of Medicine and finished her residency training in anesthesiology at the Philippine General Hospital. She pursued further training in neuroanesthesia at the same institution. Dr. Christie also obtained a master's degree in business administration from the Ateneo Graduate School of Business. She is currently an active consultant at Medical Center Manila and Makati Medical Center. She will be talking on temperature monitoring. And for our third speaker, Dr. Sheila Ann Datucon Lim. Dr. Datucon finished her medical studies at the University of the Philippines College of Medicine under the InterMed program. She had her training in anesthesiology at the Philippine General Hospital and pursued further training in thoracic and cardiovascular anesthesia at the same institution. She is currently affiliated with Cotabato Medical Specialist Hospital and Notre Dame Hospital. She is also an active consultant of Cotabato Regional and Medical Center. She'll be talking on invasive monitors. So is it 3 o'clock now? We can start. You can prepare your questions. So those who cannot come in front or those who do not want to be identified, please just write your question on a piece of paper, and then we can read it. So may I now call on Dr. Stephanie Jane Xiao.
Good afternoon, everyone. We'll make this a working symposium. So I'd like to describe a scenario for you. Supposing you were on duty and the surgeons called you for an emergency exploratory laparotomy. They told you they already intubated the patient because he had deteriorating GCS, and they stabilized the patient hemodynamically with fluid resuscitation. Now the patient is already in the operating room and you were transferring him. So this is the ECG tracing and the pulse ox reading, which is not uncommon when you're moving the patient. And then you thought of hooking the patient to your anesthesia machine with a capnograph. You see this pattern. So should you be worried? If you're not sure, then sit tight and listen to my short presentation. I'm Dr. Stephanie Shao, and my objective is to let you know that you should not ignore the capnograph reading in your monitor, to highlight the importance of capnography for patient assessment and monitoring, to explain the physiology behind it and how the capnograph works, as well as to correlate it clinically. I'd like to define some terms first. So the numerical value of carbon dioxide level is displayed in capnometry. Capnography is a graphical display of the carbon dioxide versus time, and the capnograph machine produces the graph. We use the capnograph to verify endotracheal tube or LMA placement. The American Society of Anesthesiologists recommend it as a basic monitor for ventilation in all patients who undergo general anesthesia, as well as patients who are given moderate or deep sedation. It's also a measure of the effectiveness of your CPR, as well as a parameter to detect return of spontaneous circulation. In the succeeding slides, I will rationalize its use. So we first start off with the basics, the physiology. So carbon dioxide is produced by the body as a byproduct of metabolism. Then it is carried by the RBC to the right side of the heart, then subsequently to the lungs and excreted out from there. Okay, it passes through the anatomical dead space and the breathing systems before it can be read by the capnograph. So, knowing the physiology, any changes in metabolism, circulation, respiration, or deformity in the breathing system will affect your capnograph reading. So, as a recap, because this is really important, so carbon dioxide is a byproduct of metabolism, will be carried by blood, go through the right side of the heart, and then go to the lungs, excreted from there, and for it to be read by the capnograph, will pass through the anatomical dead space and the breathing systems. I will first discuss metabolism. So there is a directly proportional relationship between metabolism and carbon dioxide production. So in other words, conditions that increase metabolism, including the following, will also increase your carbon dioxide production. On the flip side, if you decrease the metabolism while the patient is hypothermic or you're in a deep depth of anesthesia, your carbon dioxide production will also decrease. Okay. Carbon dioxide is then carried by the blood to travel from the veins to the right side of the heart and then to the lungs before it can be excreted. If the blood doesn't make it through the right side of the heart, then you won't have a capnograph reading at all. So that makes it an indicator of circulation as well. We move on to respiration. When carbon dioxide reaches the lungs, it is removed by ventilation of the alveoli. So deoxygenated blood from the right side of the heart is rich in carbon dioxide. So this carbon dioxide diffuses out of the alveoli and into the anatomical dead space. So when you have hypoventilation or you're breathing, your end tidal carbon dioxide level will increase. And if your patient doesn't breathe, or if your mech vent breaks down while the patient is paralyzed, you won't have an end tidal reading. Carbon dioxide needs to reach the capnograph to be read, and it passes from the alveoli to the anatomical dead space, and then the breathing systems which includes either an LMA or an endotracheal tube, or even just your airway adjuncts like nasopharyngeal airway, or just the natural airway. So any blockage on the structures I've enumerated will decrease your reading. So how does it work? How does it produce the graph and the numerical value? The technology used is an infrared light technology. So carbon dioxide is a polyatomic molecule which absorbs light, infrared light,